discussion on the anatomy of the wrist as it relates to distal radius fractures. The distal radius is an articular plateau for the proximal carpal row. The proximal carpal row is made up of the scaphoid, the lunate, the triquetrum, and the pisiform. The scaphoid and the lunate articulate with the distal radius. Let's look at a topographic anatomy transverse section of the distal radius articulations. The scaphoid facet is a transverse spade-shaped depression on the distal lateral aspect of the radius, which articulates with the scaphoid. The lunate facet is a vertical oval depression on the distal medial aspect of the radius. About 50% of the lunate articulates with the lunate facet of the distal radius, and the ulnar 50% of the lunate rests on the TFCC. Further ulnarly, we find a longitudinal shallow depression on the medial aspect of the radiometaphysis called the sigmoid notch. The sigmoid notch is concave and semicircular and articulates with the ulnar head. The most radial portion of the TFCC also takes its insertion point at the distal margin of the sigmoid notch. Let's look at the normal radiographic angles of the distal radius. These standardized parameters need to be restored when treating fractures of the distal radius. To obtain a radial inclination, lines are drawn across the longitudinal axis and the articular surface of the radius. The radial inclination angle of about 22 degrees is formed between a perpendicular line to the longitudinal axis of the radius and a line across the articular surface. On a lateral radiographic view, the volar tilt is obtained by drawing a line perpendicular to the longitudinal axis of the distal radius and another line drawn from the dorsal lip to the volar lip of the distal radius. The normal angle is about 11 degrees with slight variation. The radial height or radial length is measured on the PA radiograph as the distance between a line perpendicular to the long axis of the radius passing through the distal tip of the radial styloid. The second line transects the distal articular surface of the ulnar head. The normal average height is 10 to 13 millimeters. Now let's take a look at the dorsal distal radius bony anatomy. The radius has a dorsal rim, the Lister's tubercle. If you feel your own wrist with your thumb on the dorsal distal radius, the small bony protrusion is your Lister's tubercle. It acts as a pulley for the EPL tendon. Radial to Lister's tubercle is the groove where the extensor carpi radialis brevis tendon resides. The radial styloid has a triangular appearance and is the most radial aspect of the distal radius. And here we can see the ulnar styloid process of the ulna. Let's look at the anatomy of the volar side of the wrist. Understanding this topography is key for proper volar plating of the distal radius, the most common type of fixation. Here is the radial styloid, then the watershed line, which marks the distal footprint of insertion of the pronator quadratus muscle. Of relevance, this anatomic landmark helps determine the most distal extent that hardware can be placed. Any further distal to this watershed line, and the hardware will rub on the flexor pollicis longus tendon and can cause attritional rupture over time. The pronator quadratus muscle insertion covers the distal radius and must be elevated to get access to the pronator fossa, which is where the plate will be placed. Next, the volar radial ridge is shown. It is a small ridge of bone that marks the radial limit of the pronator quadratus muscle. When placing hardware, it is important to remember to have the plate ulnar to this ridge. The first dorsal extensor compartment sits at the level near the radial styloid. It is comprised of the abductor pollicis longus and extensor pollicis brevis tendons. Often, surgeons will elevate these structures when reducing a fracture. The lunate facet sits on the ulnar side of the distal radius. Anatomic reduction of this articular facet is important when fixing a distal radius fracture to prevent volar subluxation of the proximal carpal row. Now let's further detail the distal ulna as it anatomically relates to the distal radius. The ulnar head is largely covered by articular cartilage and is cylindrical in shape. The dorsal and volar radial ulnar ligaments insert at the base of the ulnar styloid process. The ulnar groove lies dorsal to the ulnar styloid. The extensor carpi ulnaris tendon resides in this groove. Next, the TFCC, or triangular fibrocartilage complex, covers the ulnar head and provides a gliding surface for the ulnar half of the proximal carpal row, as well as stabilizing the distal radioulnar joint. The TFCC attaches from the ulnar styloid to the sigmoid notch of the distal radius. It is made up of a superficial portion and a deep portion of the dorsal and volar radioulnar ligaments. This image is a volar view and shows only the volar, not dorsal, radioulnar ligament. The superficial portion is the capsular attachment of the ulnar styloid. The deep portion is the foveal attachment on the ulnar styloid and is more specifically called the ligamentum subcarinum. This is the structure that is repaired back down to the bone in a TFCC foveal repair. Let's focus in on the TFCC and its attachment to the ulnar styloid. There are several different structures that comprise the TFCC. The central portion is called the articular disc, flanked by the dorsal distal radioulnar ligament. Here we see only the superficial portion of this ligament. On the palmar side lies the volar distal radioulnar ligament and its superficial portion. Both of these ligaments attach to the ulnar styloid. These ligaments are responsible for keeping stability and hold the distal radius and ulna together to form the DRUJ, or distal radioulnar joint. The distal radioulnar joint is shown here. Some additional structures are the prestyloid recess of the TFCC, the capsule outside the TFCC, and the ECU tendon running in the ulnar groove dorsal to the ulnar styloid. The ligamentous anatomy in relation to distal radius fractures lies in the volar and dorsal ligament complexes. The volar ligament complex is comprised of the radioscaphocapitate ligament, moving ulnarly to the long radiolunate ligament, the radioscapholunate ligament, the short radiolunate ligament, and the ulnocarpal complex made of the ulnolunate and ulnotriquetral ligaments. These are also known as the cardinal ligaments. The dorsal ligament complex is comprised of the dorsal radiocarpal ligament, which connects from the radius to the triquetrum, and the dorsal intercarpal ligament, which connects the carpal bones from the triquetrum to the distal scaphoid. Finally, shown here are the arteries and nerves that are important to acknowledge during surgery when repairing a distal radius fracture. The radial artery lies on the radial aspect of the forearm, at the level of the distal radius where the pulse can be felt over the anatomic snuff box. Right before the radial styloid, the radial artery splits into the superficial palmar branch of the radial artery, which feeds the palm. The median nerve runs from the forearm into the hand through the carpal tunnel. The palmar cutaneous branch of the median nerve splits off of the median nerve right at the level of the distal radius. It provides sensory innervation to the middle palm of the hand. For a discussion on the biomechanics of distal radius fractures. Distal radius fractures are one of the most common injuries in orthopedic practice. They make up 8 to 15% of all bony injuries in adults, with more than 640,000 cases per year in the United States alone, many of these cases requiring surgery. Distal radius fractures are often associated with scapholunate and lunotriquetral ligament tears, TFCC tears, DRUJ instability, and carpal tunnel syndrome. Distal radius fractures have a bimodal distribution between young and old. Males aged 10 to 25 years are injured due to sports and auto accidents, and women older than 60 due to falls, osteoporosis, and osteopenia. Women, especially Caucasian, are 4 times more commonly affected than men. There are 5 basic types of fracture to identify: Colles, Smiths, Bartons, Chauffeurs or Hutchinson, and die punch fractures. The most common fracture pattern is the Colles fracture, named after Abraham Colles, described in 1814. This extra-articular fracture occurs after the common fall onto an outstretched hand, or a fouche, where the distal radius fragment is displaced dorsally. Colles fractures account for 90% of all distal radius fractures. Colles fracture is defined as metaphyseal injury of the corticocancellous junction, within 2 to 3 millimeters of the articular surface of the distal radius, with characteristic dorsal tilt, dorsal shift, radial tilt or radial shift, supination, and impaction. A Smith's fracture, also referred to as a reverse Colles fracture, is the exact opposite of Colles fracture. When falling, the wrist is turned inward. Smith's fracture has a palmar tilt, or a volarly displaced fragment of the distal radius. It accounts for about 5% of distal radius fractures. The dorsal, or reversed Barton's fracture, is an intra-articular coronal plane fracture of the dorsal lip of the distal radius, with dislocation of the carpus along with the fragment. Barton's fracture occurs with the wrist in palmar flexion and involves the volar lip. Barton's accounts for a small percentage of all fractures. Chauffeur's fracture was originally described as occurring due to the crank backfiring while hand cranking early car models. Sudden backfiring placed the hand in ulnar deviation with a force through the radial styloid. Today, high-energy injuries frequently cause shear and impaction of the articular surface of the distal radius with fragment displacement. Scapholunate ligament injuries are associated with this type of fracture due to the force continuing down the scapholunate interval and through the carpal bones. The die punch fracture is a very unstable interarticular fracture that is not commonly seen and is difficult to treat unless fragment-specific plating is available. It's due to a severe compression force on the lunate fossa from an axial load. There are several associated injuries with specific distal radius fractures, but the most noteworthy is the common ulnar styloid fracture. If only the distal 10% of the ulnar styloid is involved, it is not a significant problem as the TFCC is not affected. However, if the ulnar styloid fracture involves the proximal third of the ulnar styloid, there is a probable disruption of the TFCC, and the DRUJ is most likely unstable. Surgical repair is required. As mentioned earlier, most distal radius fractures are caused by a fall on the outstretched hand, or fouche, with the wrist in dorsiflexion. The form, localization, and severity of the fracture and the concomitant ligamentous injury of the wrist depends on the position or the angle of the wrist at the moment of impact with the ground. Pronation, supination, and abduction determine direction of force, compression of the carpus, and the different appearances of ligamentous injury. The radius initially fails in tension volarly, with the fracture progressing dorsally where bending forces induce compressive stresses, which may even result in dorsal comminution. Earliest attempts at classification were made during the 1930s by Nissen Lai. Later, Gartland and Worley in 1951 and Lidstrom in 1959 developed systems that were based on the presence of displacement at the site of fracture and involvement of the radiocarpal joint. More recent well-known systems are the Frickman, Malone, AO, and Fernandez classification systems. These systems are good to know, though simple fracture description of a specific patient case is more helpful. A fracture is easily described as open or closed, intra or extra-articular, and whether there is displacement, angulation, and associated injuries. Radiographic imaging is important in diagnosis, classification, treatment, and follow-up assessment of distal radius fractures. A posterior anterior view and a lateral view are considered routine minimal evaluation. According to the work of several authors, restoration of articular congruency is of utmost importance. Acceptable deformities in the AP view are radial shortening of 1 to 5 millimeters, radial inclination of 0 to 5 degree loss, and an articular surface offset of 1 to 2 millimeters. Acceptable deformities in the lateral view are 10 degrees of dorsal tilt, 20 degrees of volar tilt, and articular surface incongruity no greater than 1 to 2 millimeters. It has been reported that 100% of wrists with articular incongruencies of 2 millimeters or more develop post-traumatic osteoarthritis. Surgical reduction is suggested for articular incongruities greater than 1 to 2 millimeters after closed reduction, followed by post-reduction radiographs for further assessment. To be more specific about grading the result of a distal radius fracture reduction, here is a radiographic reduction criterion chart. This chart outlines reduction and results achieved on a scale from poor to excellent. A CT scan can give significant information in comparison to conventional radiographic evaluation of complex or occult fractures, distal radio-articular surface, distal radio-ulnar joint, ventromedial fracture fragment as described by Malone, assessments of fracture healing, and post-surgical evaluation, especially when plain films are normal. Imaging in axial and sagittal, or axial and coronal planes with 2 millimeter contiguous sections is usually sufficient. MRI is also a powerful diagnostic tool to assess bony, ligamentous, and soft tissue abnormalities associated with distal radius fractures. MRI can be used to visualize perforations of the TFCC and of interosseous ligaments to the proximal carpal row, to evaluate occult fractures, post-traumatic or avascular necrosis of carpal bones, and flexor or extensor tendon injuries. It may also be used to assess median nerve and carpal tunnel disease after malunion of a distal radius fracture. The basic principles of fracture treatment are to achieve accurate anatomical fracture reduction and then to use a method of immobilization that will effectively maintain that reduction. The goal of treatment is to limit complications and restore normal function. More specifically, volar tilt should be less than 15 degrees, dorsal tilt less than 0 degrees, radial shortening less than 3 millimeters, and intra-articular displacement or step-off less than 2 millimeters. There are conservative and surgical approaches to treating distal radius fractures. All fractures characterized by minor comminution, with or without minimal displacements, can be considered for closed reduction and cast immobilization. Mainly type 1 and type 2A Malone's fractures can be managed conservatively. The fracture should be kept under close observation to look for any redisplacement. There's no clear consensus on the best position and duration of immobilization of the wrist, nor on the need to extend the cast proximal to the elbow. However, the most optimal position of hand function is with the wrist in dorsiflexion. Surgical options include closed reduction and percutaneous pinning, closed reduction with external fixation, open reduction and internal fixation, and arthroscopic assisted fracture reduction. Finally, the type and frequency of complications in distal radius fracture varies. Mina and colleagues found overall complication rates ranging from 6 to 80% and rates of post-traumatic arthritis that range from 7 to 65%. The most frequent complication is malunion with an intra-articular or extra-articular deformity. Others include non-union, hardware complications, tendon attrition or rupture, neuritis of the median nerve, reflex sympathetic dystrophy, wound infection, and late post-traumatic arthritis. Surgical considerations in fractures of the distal radius. Let's review the surgical options for the treatment of distal radius fractures. Closed reduction and percutaneous pinning may be done in the OR for simple fractures, especially in children. Closed reduction with external fixation does have its indications. However, the most common treatment today is open reduction and internal fixation. Arthroscopic assistance is getting more traction as it provides an objective assessment of adequate intra-articular reduction. Let's cover these treatments one by one. Extra-articular distal radius fractures with extensive comminution, or fractures that have no more than 2 articular fragments where anatomical reduction is possible, may be fixed with percutaneous pinning and application of a plaster cast. The most popular pinning method is oblique radial styloid to proximal ulnar cortex. Lambot in 1908 first suggested a single pin through the radial styloid to stabilize the displaced fracture fragment. De Palma later introduced the concept of ulnar radial pin fixation for fractures with articular surface involvement. External fixation is generally accepted as superior to plaster immobilization in young patients with an intra-articular comminuted fracture. Other indications include unstable extra-articular fractures with significant comminution, failure to maintain reduction in a closed cast, certain situations of multiple trauma, presence of a dysfunctional contralateral limb, severe open fractures with significant soft tissue trauma and neurovascular compromise, and bilateral injuries. External fixation relies on the principle of ligamentotaxis to apply traction and restore displacements. The external fixator distracts the wrist joint by placing pins in the radius and the metacarpals in a 45-degree plane from true vertical and true lateral. The distal pin angles slightly proximal, and the proximal pin angles slightly distal. The radial shaft's threaded pin is placed between the brachioradialis and extensor carpi radialis longus muscles. The fixator clamps and connecting bars are then positioned, and while maintaining the distraction reduction maneuver, the clamps are tightened and secured. Though effective, this method is unable to reduce die punch fragments. It is also important to note that greater than 2 to 5 millimeter ligament distraction affects the ability of the FDS and MCP joints. Over-distraction may cause excessive palmar flexion or ulnar deviation. Another method for treatment of distal radius fractures is the use of open reduction and internal fixation, or ORIF. There are two groups of fractures for which ORIF is advisable. The first group is the two-part shear fracture, or Barton's fracture. Although reduction is possible by closed means in some cases, shear fractures are very unstable and difficult to control in a cast. The second group includes complex intra-articular fractures in which the articular fragments are displaced, rotated, or impacted and cannot be reduced through limited operative exposure. ORIF achieves articular congruency in patients with comminuted intra-articular fractures. There are many different methods for ORIF. The most common and current standard of care today is volar plate fixation. The rigid biomechanical construct allows near immediate functional wrist loading, though it may pose a significant risk by tendon attritional ruptures to the FPL and FDP. Dorsal plate fixation was popular in the past and is still used for specific fracture patterns. However, in some cases, it can lead to irritation of the extensor tendons. Dorsal plating may not support the articular surface as well as volar plating. Fragment-specific fixation is reserved for fragments so small and comminuted that they require multiple different plating techniques to fix them. The three-column model of the distal forearm described by Rickley and Regazzoni is a simple concept that aids to understanding some typical features of distal radius fractures and assists in planning internal fixation. There are plates specific for the different columns of the distal wrist. The radial styloid plate is used on the radial column. The volar hook plate on the intermediate column, and the ulnar styloid on the ulnar column. The spanning plate, shown in this radiograph, serves as an internal fixator, acting on the principle of ligamentotaxis, much like external fixation. Intramedullary nailing is yet another option for ORIF, useful for extra-articular and simple intra-articular fractures. Let's now review the key anatomic landmarks to consider for the volar surgical approach to the distal radius. The flexor carpi radialis, or FCR, and the radial artery need to be identified, retracted, and protected. It is not usually in harm's way through the volar approach, but we always need to be aware of the median nerve and its recurrent motor branch. The modified Henry approach is the most common surgical approach to the volar aspect of the distal radius. It uses the interval between the FCR and the radial artery. It is preferred to retract the FCR and the radial artery onto the same side radially, so that the FCR provides protection to the radial artery from the retractor itself. The pronator quadratus has to be peeled off to access the bony surface of the distal radius. There are different ways to approach this. Some surgeons make an L-flap with the proximal portion attached, so that the muscle can be reattached after hardware placement. More commonly nowadays, surgeons take a split longitudinal approach. There's controversy whether the PQ should be repaired or not, though the current trend is leaning towards leaving the muscle unrepaired. Once the bony surface is fully exposed, the hardware is positioned proximal to the watershed line. Remember to start reconstruction with the simpler side of the fracture, and consider fragment-specific fixation options if necessary. A temporary non-locking screw in the oblong hole helps to slide the plate. Radiographs are then used to assess the ideal position of the plate. Joseph and Harvey proposed the intraoperative fluoroscopic dorsal horizon view to assess potential dorsal screw protrusion. This came as a result of wrist lateral views only having a 75% sensitivity to detect screw penetration due to the presence of Lister's tubercle. 90 degrees of flexion exposes the dorsal cortex the most by moving the carpal bones out of the beam. Based off this view, Harvey and Joseph changed their screw length 26.6% of the time. Flexor tendon rupture is another surgical complication if a plate is misplaced. The frequency of FPL rupture is reported to be 1 to 12%. Lim Thang and colleagues performed a study comparing different types of plates and found that the FPL tendon rubbed against most of them. As a consequence, flexor tendon rupture may occur as soon as a few weeks or even years after surgery, depending on how prominent the hardware is. Soong and others indicated that a volar plate placed at the watershed line or distal to that was more likely to result in tendon rupture. Another study by Tanaka and others showed that pinch and wrist extension performed simultaneously increases the contact pressure at the FPL when a volar plate is placed distal to the watershed line. A question to consider would be when to operate. According to Nurk and Jupiter, articular malalignment of greater than 1 millimeter indicates surgery. Restoring step-off and articular congruity is key to minimizing the future risk of development of osteoarthritis. Loss of radial height or shortening greater than 10 millimeters also indicates surgery. Dorsal angulation greater than 10 degrees, or in other words, greater than 20 degrees from the normal anatomic volar tilt of 11 degrees, indicates surgery. Other reasons are DRUJ extension and associated intrinsic wrist ligament injuries, open injury, and neurovascular compromise. Here is a radiographic reduction criterion chart from LaFontaine's stability assessment. This chart outlines reduction and results achieved on a scale from poor to excellent, based on the criteria of deformity, dorsal angulation, shortening, and radial deviation. Let's finish with 3 case examples to show how certain plates may be used. The first case is with a radial styloid comminuted fracture. With a volar approach, the radial styloid plate initially fixed the radial fragment, then the wrist was dorsally spanned. The dorsal spanning plate can be seen also maintaining and stabilizing the distal ulna fracture. The spanning plate was removed after 12 weeks. The next case presented with both volar and dorsal intraarticular fragments. A dorsal plate aided to buttress dorsally, while the volar plate retained volar tilt and helped to scaffold beneath the articular surface. This last case is severely comminuted dorsally with an ulnar neck fracture. After reducing out to length, a dorsal plate was placed to fix the radial height in combination with a volar hook plate to stabilize the lunate facet. Intraarticular fractures of the radius can be arthroscopically assessed and reduced, along with repair of ligamentous injury. An arthroscopic assisted surgery is best done 3 to 7 days after initial injury, because if it is performed later, there may be difficulty in manipulating the bone fragments. Fluoroscopy can be used to find portals when there is soft tissue swelling and distortion of osseous landmarks. Standard traction technique may be used for simple fractures, such as those of the radial styloid. Arthroscopy is contraindicated for patients with extensive soft tissue injuries, median nerve symptoms, compartment syndrome, or an open joint. Discussion on the clinical applications in the treatment of distal radius fractures with open reduction and internal fixation with dorsal distal radius plating. In this video, Dr. Chris Martin performs a dorsal distal radius plating technique using the dorsal T-plate.
So we're going to do a dorsal approach to the distal radius. The first landmark used is generally the styloid and Lister's tubercle. And we're going to come in straight over the carpus and just right down the center of the radius. And then dissection goes down to the retinaculum. This areolar tissue is used to elevate and expose the retinaculum widely, and taking care of looking for the superficial radial nerve on this side. And the extensor pollicis longus is a useful landmark as that exits the retinaculum, and then bring an incision straight over the retinaculum out the extensor pollicis longus. And then a portion of this flap can be elevated depending on the fracture. If one needs wide exposure to the joints, this can be elevated off of the fourth dorsal extensor compartment, or sometimes left on for an extra-articular fracture. And the proximal retinaculum is taken all the way over to the fifth dorsal extensor compartment, so we get a nice wide piece. And there's the tendon of the fifth showing up, and then brought back as a large flap off the fourth, and then back to the third, and onto Lister's tubercle. So with the EPL as the landmark, we'll release this retinaculum from the EPL, preserving this. And once the EPL is exposed, that gives us access to Lister's tubercle. And then we want to stay as subperiosteal as you can. The retinaculum can thin out in this region, especially proximally. So taking some of this periosteum between the third and the second compartments is often useful. There's our periosteum and the second compartment. Just a little more off the second compartment. And now we're exposed. So I have this large capsular retinacular flap that we'll use later in closure. I'm going to put this retractor between the third and fourth dorsal extensor compartments. Generally release a little more fascia there. At this point, I'll identify and excise just part of the posterior osseous nerve. And periosteum on both these sides is useful, especially ulnarly. So I will elevate off of the fracture site out distally, trying to preserve any tissue I can to sew into. That'll be helpful during the retinacular closure later. And then the joint line can be felt. And to allow access to the joint, the capsule is reflected off of the dorsal lip of the distal radius. So in a specimen here, we don't have traction in that advantage, but this can be pressed down. I can see into the joint, visualize this fairly well. So the access to the joint, here's my scaphoid facet, working over to the lunate facet. A little tougher to see, but can be seen, especially under traction. Very frequently, the fracture line in the joint is going to be extending up here, and if a knife or elevator is placed first into the fracture line, then the soft tissue at the dorsal lip of the radius can be released, and these frequently scaphoid facet and lunate facet fragments can be booked open, affording access even down deep in volar. And now we need a rongeur. Lister's tubercle is frequently a comminuted separate fragment in the specimen. We're just going to simply remove it. And if there is reasonable bone, it can be just placed in the fracture site and used as graft. Now this central tissue and periosteum back in this region is exposed. Here's our first dorsal extensor compartment back here. The plate's going to slide under that, so I'm going to use some type of elevator. Simply create a pouch underneath the first dorsal extensor compartment. And now we're ready for some type of plate. Here's a narrow plate. We have a fairly small specimen, so that looks like the best fit. So this plate slid back under the pouch, and then with a drill guide, one of the oblong drill holes will be selected first, depending on our degree of comminution, either here or even back here onto the shaft. And then before tightening this, we want to make sure that we've got the distal portion of the plate where we want it in relation to the joint. So again, we can inspect our fracture site. Remember, the articular surface is always curving away from us just a little bit, away from this ridge. And I want these screws to be able to come down right in the subchondral bone. So something in that neighborhood looks pretty good. So once I'm happy with the position distally relative to the articular surface, I'm going to buy that position and secure that screw. And let's go distally now. And all these screws are designed to go down roughly parallel. So in effect, this is going to give us a platform made of screws directly in the subchondral bone. So with several ways to put these in. So second, we'll stay on the scaphoid facet. Use this drill guide. Drill is also calibrated. You can use a regular depth gauge or the drill guide. So our volar cortex measures 19, and we'll put in a 20 screw. Here we're going centrally, frequently in intra-articular fractures. This central screw between the scaphoid and the lunate facets is not as useful as frequently in the area of comminution. So I can feel bone all the way down onto the volar cortex and .24. I'm a lockdown. And then the beauty of the dorsal approach, I don't need C-arm at all at this point. And if I'm worried about the joint surface or my comminuted fracture, I can always check it directly. And I've got no penetration. So looking good. We're going to move ulnarly and now use the variable angle type drill guide. And this drill guide is designed to seat within the plate. And inspecting that, I can look at the joint surface, know where I want to go, and aim this plate accordingly. So this one we're going to go just a little bit ulnar even. The screw is not in the joint. I will fill one last articular screw hole. This is cinched up and locked, and now remaining, we're just going to switch around and secure the rest of the plate on the shaft here. So given two elongated holes, it gives us more flexibility to be able to choose the length where to put this distal portion. And very frequently, this whole area is too comminuted to allow sufficient purchase in that screw. So having the second elongated hole proximally gives us a lot of freedom in that regard. So now we'll do two locking screws proximally. Another 14. And then our choice here is either one more slight pull. That's going to give us access there. And on occasion, we do split between the two muscles of the first dorsal extensor compartment. Now we're between and get back proximally to this last screw hole. All right. So after our fixation, I'm going to directly inspect this joint. And here I've got no screw penetration. I know I've got a good reduction. I can see it both directly, and then we'll confirm this on C-arm as well. But I know that inspecting it directly is more accurate. Now that we're happy, we're going to go to closure. I'm going to take a little bit of tension off of this EPL, just mobilize it just a touch, release some of the fascia. So first is our capsular repair. Sometimes we can leave a cuff of tissue here, and if we haven't been able to do that, this plate provides two areas to fix the capsule back to the dorsal lip of the radius. One more again, I did not save much tissue there, so the plate is going to bail us out. And then we'll lay the retinaculum over. So the retinaculum, we save this as a wide flap because I'm going to use the distal portion of the flap to help with my plate and try and minimize our risk of tendon irritation. So I'm going to divide this all the way down to the floor between the first and the second compartments. Then the tendons of the second are raised up. This retinacular flap is passed through, and now these tendons can retract out of the way. And we'll proceed with closure over here. Here's where this ulnar periosteum was useful to save. Sometimes it can be used to cover the plate. Sometimes it can just be used to help reapproximate the retinaculum. And here I can go to the periosteum or reinforce the capsular repair. I'll add one more centrally. So the remainder of the retinaculum, I'm going to pass over the tendons of the second and fourth. The EPL is going to stay superficial. And now we're going to move up here and grab our distal retinaculum. We know that we need roughly a centimeter of retinaculum for this to remain functional. And here we'll have no problem achieving that. Okay, so the EPL will be left superficial, and the rest of this will simply be closed up, and there we are. And the remainder of the wound is closed in layers as usual. So the first thing about dorsal plating we know is we are so much closer to the joint than we're used to with volar plating that sometimes these plates will look like they are above and into the joint. But we need to remember that the dorsal lip comes out distally a fair amount. And surgically, we were right here looking at this bone. So we know this plate is not prominent, not riding over the joint. The same is true for the ulnar screws. We put these in under variable angle, and we know they're directly beneath the subchondral bone. X-ray wise, it gives us a good angle, and we even got this ulnar screw aimed more into the volar ulnar corner, which is generally a difficult place to get to with plating. And then we have our capsular reattachment back here. So position-wise, everything looks good with that plate. Laterally, we can see these screws come down and form a scaffolding right below the subchondral bone. We've got a good idea of this bone coming in there. Same thing as volar. We've got our more radial screws are slightly distal. Ulnar screws are slightly back to make up for the inclination of the radius. So lateral-wise, we look good. This is an unusual view looking end-on, but it demonstrates some of the versatility of this plate. This allows us to form a scaffolding of parallel screws directly beneath the articular surface. And with these ulnarmost screws, we can get near the sigmoid notch down into that volar portion of the lunate facet, which is a notoriously difficult place to get from volarly.